everyone. This is Denise Kokis, Research Advisor at the Endometriosis Foundation of America. Welcome to our Research Spotlight today. We have joining us Dr. Hugh Taylor and Dr. Valerie Flores at the Yale School of Medicine. So thank you both for joining us today. We really appreciate the time you're taking to meet with me. I'm gonna give the floor to you. Could you both just introduce yourselves? Maybe we'll start from Dr. Taylor.
Yes, thanks, Denise. First, I'm Hugh Taylor. I'm the chair of obstetrics and gynecology at the Yale School of Medicine. I'm a reproductive endocrinologist and endometriosis surgeon who not only takes care of patients with endometriosis, but we're doing basic and translational research and trying to understand the biology of endometriosis, understands how it causes pain, causes inflammation, causes infertility, and looking at ways we can use that information to help treat patients, coming up with specific diagnostic techniques to identify endometriosis sooner and treat endometriosis better in ways other than just hormonal suppression.
And I'm Valerie Flores. I'm an assistant professor in the Department of OBGYN. I'm also a reproductive endocrinologist and fertility specialist with a specific interest in endometriosis. And I'm also a reproductive scientist development program K-12 scholar. And I work under the mentorship of Dr. Taylor, reiterating exactly what he said. We're really looking at the molecular mechanisms of what's causing endometriosis, how we can better treat women, and how we can develop more innovative therapies for these women.
And Denise, before we go any further, I'd like to just thank you and the foundation for your support, for all you're doing for the field, and for your members and generous donors who've made all this possible. We're really making some huge advances, and in large part due to your foundation and its supporters. Thank you.
Thank you, and that's great to hear. And we're very grateful for the work that you both are doing. So thank you to you as well. We'd like to hear a bit about your research, but before I go into that, I just want to ask both of you, what inspired you to do this research on endometriosis and get into the field of endometriosis?
Valerie, I'll let you go first then on this one.
So I actually had an aunt who had endometriosis who relayed to me her struggle with endometriosis when I was in medical school, which was also at Yale, and that's how I met Dr. Taylor. And so when I returned to Yale for fellowship and then ultimately stayed on as faculty, I knew that the research that I wanted to do was related to endometriosis, just because seeing the struggles that my aunt had, both from a pain perspective and ultimately an infertility perspective, really motivated me to try to find ways to not only help her, but also help future patients.
And my story is very similar. It's the patients who drew me in. I came into this field with a background in science, was studying actually developmental biology, how the uterus functioned, but I was struck by the suffering that I saw in my endometriosis patients, the pain, the infertility, the years of suffering before the disease was diagnosed, and the still need for more treatments. We don't have perfect treatments today. So it's really the patients and working with them and empathizing with them that really drew me in to focus my research more on endometriosis.
Yeah, there's so much unknown in the field of endometriosis. I think we have a lot to do in terms of understanding the disease and treating and managing it as well.
Mm-hmm.
Thank you for sharing that, both of you. So just moving on to the research grant that you received from us in last year in 2019. So I know that that is mainly looking at progesterone receptor expression. So could you tell us a bit more about that research grant and what it involves?
Valerie, why don't you
start with this one? Yeah. So In thinking about endometriosis, while we commonly know that it grows in response to estrogen and tends to be progesterone resistant, what I found intriguing was that we haven't actually utilized whether or not hormonal receptor status can be a biomarker for predicting response to existing hormonal therapies. And so my first project was aimed at really determining whether or not we could use specifically progesterone receptor expression to determine who would or would not respond to progestin-based therapy, which is first line. And the reason why I wanted to look at that is I had noticed in the clinic that patients frequently would come in having failed progestin-based therapy, and they'd been on it for months to years. And if we could develop a test that could say you will or will not respond to this therapy, I thought it would be so much better for patients. They wouldn't have to go through months of struggling to find the right therapy for them. And in order to test this theory, I looked at endometriotic lesions and stained them for progesterone receptor expression, or sorry, for progesterone receptor, and found that there were actually variations of PR expression. So unlike what we commonly thought, which was that if you were progesterone resistant, it most likely meant that you did not have a lot of progesterone receptor expression, I found that it was actually quite variable, and I could even categorize the lesions as having high, medium, or low PR expression. And then based off of that, I looked at whether or not women had responded to progestin-based therapy and found that all women who had high PR expression in their lesions did in fact respond to progestin-based therapy, while those that had low PR expression, there was only a 6% chance that they would have responded to a progestin-based therapy. All of these women did undergo surgery, so most of them had already been failing therapy. And I think where we can translate that to patient care is these women do frequently undergo multiple surgeries. They do tend to come back or having failed medical therapy. And if we could say, you know what, based off of your lesions, we know that your PR is low, then we definitely should not move forward with another progestin-based therapy. We should look towards GnRH analogs or agents that target some other aspect of the disease. I want to eventually test this in a prospective study, but before doing that, I actually utilized a xenograft model because it's easier with an animal model to manipulate hormonal therapy. And so I used immunodeficient mice so that I could then place endometriotic lesions into these mice. And before doing that, and these are human endometriotic lesions, before doing that, determined their PR expression and treated these mice with either medroxyprogesterone acetate, which is the most common oral progestin, or a GnRH antagonist, so something that more directly blocks estrogen production. And what was not as surprising was that, as expected, those with high PR expression did completely respond to progestin-based therapy as well as a GnRH antagonist. But what was interesting is that in lesions that had low PR expression, while they did not respond to progestins, they also didn't respond completely to a GnRH antagonist, which made me think that perhaps PR expression not only predicts response to progestin-based therapy, but maybe it also predicts response to other hormonal agents. And with that background, that led into what the Endometriosis Foundation gave us in terms of funding, which was looking at the why. Why is it that there is low PR expression? Why is it that there is incomplete response to progestin-based therapy? And that's when we started to think about the fact that we know endometriosis is a systemic disorder. We know that inflammation is a large part of the disease. And so what is it potentially about that inflammation that could be mediating this altered PR expression? And we've had prior work in the lab looking at altered microRNAs, which are small molecules that mediate differential effects. And we know that there are also alterations in inflammatory markers in endometriosis. And so what I wanted to test was if we know, for example, LET7B, which normally, it's a microRNA that normally has anti-inflammatory properties that we have found is low in women with endometriosis. And also, interestingly enough, is involved in blocking specifically NF-kappa B, which is a very prominent marker or a mediator of inflammation. And so what I wanted to look at was whether or not we could use, or we could determine if inflammation was in somehow affecting PR expression. And so I took endometrium from women with endometriosis and gave them either a LET7B, essentially like an agonist, so a mimic that gives you the LET7B that theoretically someone with endometriosis is missing, or an antagonist, which mimics what happens an inhibitor, which normally mimics what's likely happening in endo, which is where LET7B is low. And I found that in the cells that were treated with the LET7B-like agent, there was decreased expression of NF-kappa B, so essentially decreased inflammation. And for next steps, I next want to look and see, is that in turn mediating low PR expression? Is that also resulting in epigenetic changes at the level of the gene? And is that the reason why there's altered progesterone responsiveness in these women?
Yeah, and that's so key because, birth control pills are still the first line therapy that women receive for endometriosis typically. It's the progestin in those birth control pills that treats endometriosis, and it fails so frequently, far too frequently. And understanding why would be helpful. Maybe we can devise ways to make it work better. But also identifying who's going to fail beforehand so we don't put them through months of an unnecessary trial of a useless medication would be really helpful. We can identify who needs to go on to a different approach, whether that be a different medication or a surgical approach early on. Identifying who's going to fail to respond to birth control pills is so important. Directly will impact patient care and make people's lives better if we can avoid unnecessary use of futile treatments, or make them work better. And that, I think, I'll go from there into a little bit of a bigger explanation of some of the more broader themes that we're approaching. That progesterone resistance is important, but as Dr. Flores mentioned, this inflammation associated with endometriosis is key. That this is a inflammatory disease. You get inflammation everywhere. It's not just isolated to the lesions in the pelvis, but there's broad, widespread effects of endometriosis throughout the body. And one of the key signals that does this is these microRNAs that Dr. Flores mentioned. These small RNA molecules that are made in cells and but get out into the bloodstream and can have wide impact throughout the entire body, and really understanding how those work, how they cause inflammation. And we've shown that they do cause inflammation. They trigger white blood cells to act in a way that causes them to create inflammation. It influences the progesterone receptor expression, as Dr. Flores mentioned in her works directly looking at. So this is one way that we know that endometriosis causes these whole body effects, causes inflammation that's interrelated with that progesterone response. The more inflammation, the worse the progesterone receptor expression, and the less likely you are to respond to a progestin. So those are key in understanding how they work. Could they potentially be used to alter that inflammation? Could we block them or use them? Also, we're developing diagnostic tests separate from this work. We're developing diagnostic tests using microRNAs that may help us to have a blood test where we can identify endometriosis and again get people to effective treatment by early recognition of the disease, rather than the years of suffering people unfortunately typically go through before someone actually identifies their endometriosis. So using these microRNAs and modulating their ability to cause inflammation and the progesterone resistance will be key going forward.
Yeah. So, there's a lot of exciting things that you both mentioned there. So in terms of the development of new diagnostic tools, but also, determining in advance if somebody's going to be responsive to certain treatments.
Yes.
And for our viewers that, might not be too familiar with this, why is it so important to, look at these progesterone receptors, and why is progesterone so important?
Valerie, I'll let you take this one then.
Progesterone is important just in terms of what I had mentioned briefly in the beginning. We know that there are two main hormones. To simplify it, although it's not a simple process whatsoever, there are two main hormones involved with endometriosis, and it's estrogen and progesterone. And we know that lesions absolutely grow in response to estrogen, but what should normally happen through the menstrual cycle is that progesterone essentially stops growth. The term we use is decidualization, but it's really just a sense of just lesion regression to prevent any further growth. And so it kind of counteracts estrogen's actions. And all women with endometriosis, all women without endometriosis, they have the same level of progesterone, but the issue is that for some reason the lesions just aren't responsive to it. And that's why progesterone, and on top of that, actually, progesterone has anti-inflammatory properties. And so for us, it was something that we thought was really important to look at because it's so instrumental to what should normally happen in a menstrual cycle and to what is actually going awry in endometriosis, which is this lack of response. And so if we can find ways like Dr. Taylor had mentioned, it's one thing to say it's low and we can use it to predict response to therapy, but really the next question is, can we fix that altered response? So in studying progesterone responsiveness and studying changes in PR expression and how that relates to inflammation, maybe the next goal will be developing a therapy that restores that response, and whether that's by increasing PR expression or just increasing sensitivity to native progesterone or hormonal agents would really be key to helping women.
Yeah, and that actually brings me to my next question, which was, I know you both briefly answered this, but what's the translational impact of this research on endometriosis patient care?
Well, Dr. Flores' research in particular is, already she's shown you can take endometriosis, and if the progesterone receptor is at very low levels or not there, it's not going to respond to progesterone. You can already tell somebody right now, just by looking at that receptor level, that they're wasting their time trying a progestin-based therapy. So it's already at the point where we're using it clinically to help our patients and decide who that therapy would be futile, who it's wasting their time, and who needs to get on to a more effective therapy or surgery. I think the other thing is we're not there yet, but hope by understanding the mechanism, which is what Dr. Flores is doing, understanding the molecular mechanism that makes that progesterone receptor disappear. If we really understand that, maybe we can turn it around, turn it back on, and progestins will work, and a birth control pill might be a simple cure for people where it's not working now if we can reactivate the progesterone receptor. We're not there yet, but that's a potential outcome of this research, that it could really make inexpensive therapies that are ineffective now more effective for a broader range of people.
Yeah, and that's wonderful to hear. It's really exciting. Also, I wanted to ask you, in terms of your research, what has the impact of this grant been for both of you?
Yeah. Go ahead, Valerie.
Oh, sorry. I can let you go, Dr. Taylor, if you want. I think it's been huge to be able to, so we are a huge referral center, as is New York, in terms of patients that come in. Some are completely averse to surgery, some absolutely want surgery, and some have not had a clear understanding of what are options for them. And being able to tell them that we are doing research that literally can impact their care, not years from now, but right now, is huge. So being able to show that you could use PR expression in the lesions to predict response, it's such a great quick fix for them. It's really, I think it's probably the best part of what we do, because you see these patients, you do your research, and then they come and say, I heard that you have looked at PR expression. Can you look at that when you do my surgery? And they just get so excited, and being able to help them in that way is huge. So from a patient perspective, I think it's fantastic. I'm so grateful to organizations like yours that give us really this opportunity to do this innovative research. I hope we're really making a difference for patient care. And then on a broader research-based level, I think it's been huge because I'm earlier in my career. I've been very fortunate to have Dr. Taylor as my mentor, but this grant has really helped supplement some of the existing work that I'm doing as part of my K-12 grant.
Yeah, it's been wonderful getting people like Valerie focused on endometriosis, and the availability of research funds brings more people into this field. This is an understudied disease, and I've been struck by just how much people suffer from this disease, how their lives are impacted over decades, how it's really limiting. They're missing work, they're missing school, they're not necessarily getting all of the opportunities that they might have had they not had endometriosis. When you're missing school, when you're missing work, you may miss out on important career opportunities. This is devastating to people's lives, and it's been ignored and understudied. And the NIH traditionally is our biggest funder in this country, has not put a lot of money into endometriosis research yet. It has a huge impact on these patients. And it's a very common disease. We don't understand this disease as well as we should, as well as we understand other similarly common diseases that may have even less impact on people's lives. And there's real opportunity there if we understand these diseases better, if we understand what causes them, what mechanisms drive them forward, that we can find them earlier, treat them earlier, and that we come up with new therapies that will really change people's lives. This research is essential, and your funding is helping us to advance the forefront of this disease. That this is going to help people. This is going to turn people's lives around. So this is critically important.
Yeah, and that's great to hear for us. Also, Dr. Flores, you said, you're relatively early in your career, and it's great to hear that we're supporting your development as well. So thank you for sharing that. And Dr. Taylor, you mentioned, that endometriosis is an underfunded disease. It's gotten relatively low funding from the NIH. So that's a major challenge that we as a foundation always highlight. But what are the other challenges in research on endo that both of you face in your work?
Well, it's a complicated disease that is so multifaceted that it makes it hard to understand. Again, there are people who have tremendous debilitating pain, and there are people who have no pain but extensive disease, and there are people that have infertility with no pain and pain with no infertility, and small amounts of the disease can cause devastating pain. We really just don't understand it well enough. And what I think our focus is shifting from understanding more about just the lesions to thinking about this on a whole body perspective, that there are a lot of consequences to that endometriosis being there that go beyond the lesions, that inflammation we talked about, whole body effects that we're working on. So that's the biggest challenge now, is understanding that this isn't a localized disease just in the pelvis. This is a broad systemic disease that affects almost every organ in the body and creates this generalized inflammation. Understanding that and the huge scope of the disease makes it challenging, but the fact that we now understand that is allowing us to focus on that and make some real progress there. So I think that's a major breakthrough in the last couple of years.
And I would echo what Dr. Taylor said. I think that's the hardest part of the disease, is that it is multifaceted, but we are able now to understand it more on a broader level in terms of thinking about it as not just a disease confined to the pelvis. It really is a systemic disorder, and understanding it in that way, I think, also helps in terms of developing novel therapies and really helps treat the patient as a whole rather than focusing on one given organ. And even for patients, I feel like it is under-recognized, and I feel like patients themselves may have difficulty articulating their symptoms. And so just making it more known so that they also feel comfortable discussing it with their providers is huge.
That I can't stress that enough. This is something that hasn't been talked about, hasn't been widely disseminated, the information. The practicing physicians haven't been all adequately trained in recognizing this. Often this starts in young women who are still seeing a pediatrician potentially, who aren't familiar with endometriosis. And I think that recognition is also a huge challenge. If we can get primary care doctors, pediatricians to be on the lookout for this disease, to recognize it early, we can head off a lot of suffering. If we can get people in the community to just start talking about it, not to be afraid to talk about pelvic pain, to openly speak about endometriosis, will go a long way to identifying it. If people suspect they have endometriosis, see someone, advocate for themselves, that will help a lot. I've finally seen some television commercials about endometriosis in the last year or two that I think are helping to open up that dialogue. But it was something a generation ago people didn't talk about. People didn't talk about menstrual pain. People didn't talk about pain with intercourse. Those were subjects that weren't appropriate for polite society, unfortunately. But it really was unfortunate because a lot of people did suffer terribly. I think that tide is changing, but we need to do what we can to push that envelope to get this to be an open, frank conversation where people can talk about and recognize that they may have endometriosis and see a healthcare provider who is familiar with it, knows how to recognize it and get them their appropriate treatment.
Yeah, definitely. And I completely agree. Like you said, the tide is changing, but there's so much more to do in all ends, you know, in terms of awareness among professionals, medical professionals, other healthcare professionals, adolescents, adults, everyone really.
Yes.
So there's a lot to do. Yeah, and so thank you both so much for joining us. Do you have, that's the end of my questions. Do you have any final thoughts or comments that you'd like to share with us?
No, I think we've got some other immune work that we didn't really have a chance to talk about that is still somewhat preliminary that your funding is sponsoring. So I think we're learning so much more about the immune system and that inflammation associated with endometriosis. It's a unique inflammation in some ways. It creates this whole body inflammation that can irritate a lot of organs, but it doesn't destroy the endometriosis. That's protected. And one of the other areas of research that we're working on now and expect to have some results very soon, again, thanks in part to your sponsorship, is understanding how the endometriosis evades that inflammation, why it survives and is not harmed by the inflammation. And we're finding a couple different key mechanisms that endometriosis uses to evade immune detection, to avoid the immune system, to create havoc with inflammation, but not be harmed by it itself. So very sneaky endometriosis, but we're gonna get to the bottom of it and stop it.
And I just wanted to say thank you again to the Endo Foundation. This grant has really been instrumental in helping move forward a lot of this research, and anything that we can do to help patients, we're always available.
Yeah, that's the bottom line, that this is all because we care about patients with this disease, which is why we have this passion for understanding it and beating it.
Thank you. Thank you for all the work that you're doing.
Thank you.
Thank you.